So today we'll be taking our lectures from the beginning. The other time we did something on hypertension, which is under cardiovascular pharmacology. But we shouldn't have done that. We should have started with GIT pharmacology. So there's one thing about my nature of slides. Normally, I begin with the pathology before I give the drugs. However, the questions will not be based on the pathology, but rather the drug aspect of it. So I don't know if I should quickly rush through the pathology since many of you know these diseases already. Okay, I'll quickly rush through and then follow it with the pharmacology aspects. And that's what I'll be asking questions on, not the pathology. So please let us know that pharmacology is the study of drugs and how the body handles those drugs and then what the drugs does to the body. But here we want to know what the drugs does to the GIT. Okay, so in brief, GIT disorders are among the most common reasons people seek clinical assistance. So some of the GIT disorders include peptic ulcer, dyspepsia, gastroesophageal reflux disease, GI motility disorders, constipation, diarrhea, and vomiting. I know many of you have actually encountered one of these diseases or disorders before, and there are a lot of drugs available for the treatment of these disorders. So with the peptic ulcer, it's a disease characterized by inflamed lesions of the mucosa of upper GIT. Your upper GIT is mostly acidic due to the production of gastrin, okay? And how does this damage occur? So it's caused by excessive acid and pepsin production, and also when there is inhibition of prostaglandin synthesis. Okay, so prostaglandin actually secretes mucus, especially prostaglandin E1, okay, or E2 normally leads to the production of mucus, and this lines your stomach walls, okay, preventing the direct touch of acid produced by your stomach, by the GIT. Also, infection caused by histolytica pylori, Helicobacter pylori, sorry, okay, could also cause damage to the walls of the GIT. So those at risk include smokers, alcoholics, the elderly, and individuals on NSAIDs. So here, NSAIDs are non-steroidal anti-inflammatory drugs. And what they do is that as they are taken in, they block COX enzymes. And treated something on COX enzymes, you realize that NSAIDs block both COX-1 and COX-2. COX-1 is cyclooxygenase 1, and COX-2 it means cyclooxygenase 2. But it is the cyclooxygenase 2 that helps with the production of mucus. Okay, cyclooxygenase 2 produces prostaglandin E, whilst the COX-1 produces inflammation. Okay, so when you take an NSAID, it is to help reduce inflammation. But this inflammation you are trying to reduce, you end up blocking COX-2. Okay, COX-2 enzyme, okay, helps with the production of mucus aside inflammation. So normally we give drugs selectively to target COX-1. So some examples of the drug include celecoxib, okay? And this celecoxib selectively stop the activities of COX-1. which can lead to inflammation. It blocks that COX-1, and therefore there will be no inflammation in wherever cells this mechanism is occurring. But for the COX-2, the COX-2 has a beneficial part which includes the secretion of mucus, and that mucus will line up your stomach wall. So normally, NSAIDs, before a doctor prescribes NSAIDs, he asks you, the patient, whether you have a history of maybe peptic ulcer, so that maybe taking the drug doesn't worsen the case. Now, the Helicobacter pylori induces gastritis and is believed to precede development of peptic ulcer, okay? And is found in the tract of almost all duodenal ulcer patients and about 80% of gastric ulcer patients. Please mind you, this is pathology. It's not, there will be no question on pathology, but to help us understand what is going on, that's why I have included this part to the slides. Okay, so there is evidence that eradication of the Helicobacter pylori reduces recurrence rate of ulcers. Now we move on to the next disorder, which is the dyspepsia or heartburn or indigestion, okay, and is characterized by epigastric discomfort following meals. So it is usually associated with impaired digestion and excessive stomach acidity. And some of the signs which it is accompanied with include belching, bloating, and nausea, and is also associated with the gastroesophageal reflux disease. Now, someone asked, what is the gastroesophageal reflux disease? So it is the backflow of stomach acid into the esophagus. Mind you, the stomach actually is designed to handle acidic condition. But here's the case that the esophagus, okay, is not designed to handle acid conditions. And so when the acid flows into the esophagus, the acid content or the level, okay, destroys the esophagus, and that is termed as scarring. Okay, so here the meaning is the esophagus is not equipped to handle the harsh conditions of the stomach acid, and therefore can lead to scarring. And also, usually it can also lead to the burning sensation behind the breastbone. Okay. Now, more severe symptoms include difficulty in swallowing and chest pain, because due to the harsh conditions of the acid, obviously when it comes into contact with these esophagus, cells of the esophagus, it can lead to sore and therefore makes swallowing difficult. Okay, so you can end up getting sore throat, and therefore it can even lead to esophageal erosions, esophageal ulcer, and the narrowing of the esophagus, which is called esophageal stricture. Now we move on to another disorder, which is the Zolinga-Allison syndrome. And this is a rare disorder that causes one or more tumors to form in the pancreas or duodenum. This disorder causes large amounts of gastrin to be produced by the pancreas or duodenum. And the tumor are also called gastrinomas. Okay. So what it does is that, tumor is the uncontrolled growth of cells. So here, if the cell is to perform a particular function, because it's uncontrolled, means that there will be more cells trying to produce a lot of things there. So if the cell is to produce acid, it means that there will be more cells to produce acid, and therefore exacerbates the conditions occurring in the stomach. So this then leads to the excessive production of stomach acid, which leads to peptic ulcer. The ulcers usually occur in the stomach or duodenum. Okay. Now we move on to the next disorder, which is the GI motility disorders. Okay. And these include the acute gastroparesis and irritable bowel syndrome. So as earlier I spoke about GERD, okay, and it can be considered under the GI motility disorder. So the GI motility disorder is characterized by irregular GI gastrointestinal movements, okay, and here for the GERD, it's I've already described it as a reflux or the backflow of gastric acid into the esophagus. And I said earlier that the esophagus is not equipped to handle this acid condition. Okay, so what happens? How does the backflow occur? So it is associated with decreased pressure in the lower esophageal sphincter, okay, and then for there is a backflow. Now we have the acute gastroparesis, which also causes a delay in gastric emptying and is mostly seen in patients recovering from surgery, trauma, or abdominal infection. Now we move on to the other hand of the GI motility disorders, which is the irritable bowel syndrome. For this, it is non-inflammatory disorder characterized by abnormal bowel movement. So here the bowel is often anatomically normal, okay? However, it is accompanied by diarrhea, constipation, or you have both occurring at the same time. We move on to the next disorder, which is the nausea and vomiting. So please note that vomiting is mostly preceded by nausea. So if I should translate it to P, obofun, okay, nausea before you vomit. So vomiting is a physiological response to the presence of irritating or harmful substance in GIT or blood. So here I would talk into details when we get to I think one of the slides which I explained vividly. Okay, and here it could occur by excessive vestibular stimulation. So you can have people suffering from motion sickness, that some people, when they try to commute or they try to journey using the ship or boat over the sea, due to certain things or in their eardrum, normally could cause them to vomit because their vomiting center has been triggered. Okay, another physiological stimuli which can also induce vomiting includes fear, obnoxious sight, or odor. So you can imagine maybe you sitting beside a trotro mate and he just extends his hand trying to take money from the back seat passengers, and you smelling the odor from the armpits can make you vomit. Okay, so this is the psychological stimuli which can also induce vomiting, aside the motion sickness, which is caused by the excessive vestibular stimulation. Now, for constipation, I know we've all encountered constipation one way or the other. If you've been to high school or boarding school, maybe after eating two dry breads, you know what constipation is. Constipation is characterized by the difficult passage of hard and dry stool, and the treatment of constipation rests on foundation of increased dietary fiber ingestion. So if I could share a story, I remember one time a lady was bought an orange and she ate everything in the orange and leaving the peel. So I was like, oh, you two just drink the juice and throw the rest away. She just looked at me and just told me that even if it was me, I would have done worse, indicating that I would have chewed the roughage as well as the peels. Anyway, so that was just by the way. So here is the case that taking in roughage diet or diet containing fiber can help treat constipation. And patients are mostly encouraged to take fruits, vegetables, and whole grain foods. Now we move on to laxatives, okay, which are also used to reduce constipation. So we move on to another disorder, which is diarrhea. And diarrhea is the frequency of elimination and consistency of stools, and this can vary from one person to the other. Diarrhea is characterized by an increase in the number and liquidity of a person's stool, and sometimes it can be life-threatening, okay? Diarrhea has so many causes, okay? And most cases of diarrhea are self-limiting and mostly subside within 1 to 2 days without treatment. However, severe diarrhea may occur as a result of bacterial infection, and this together with other causes can lead to significant loss of fluid and electrolytes. So mind you, wherever salt, okay, goes or electrolyte goes, water follows. And in that case, it prompts attention, okay, and therefore we patient are advised to, refill themselves with fluid, okay. Now we look at the treatment option, and that's where my pharmacology comes in. And here we are looking at the management of gastric hyperacidity. If the acid levels are high, how are you going to manage it? So in pharmacology, normally we look at what is the cause, what what causes the production of the gastric acid secretion, okay, and then how do we block it? So here we look at the acid secretion, and mostly it has physiological stimulants of gastric acid secretions being gastrin, which is the gene cells, acetylcholine, which is mostly produced by the enteric nervous system, and histamine, which is mostly found on the enterochromaffin-like cells. Now, the gastrin and acetylcholine stimulate acid secretion from parietal cells. These two, okay, they stimulate acid secretion from parietal cells. So if you're a pharmacologist, what do? You look for drugs to block these two, okay, from stimulating acid secretion from these cells, parietal cells. Now,
Hey, Nick, hello, sir. We can hear you.